Yes, we can, Nimra.
Thank you so much, Zaheen. So I am Nimra Ayaz, and I will be moderating the session for today. It is a very special day for CHSR because we are holding our first Journal Club meeting today. And the topic we've chosen for today is the risk of diabetes type 2 by ethnicity-specific BMI cutoffs for obesity. Before we start our presentation, which will be held by Zaheen Fatma, let me walk you through our panelists. So this is a group of amazing ladies which will be conducting the session today. We have Zaheen Fatma, we have Runa Khan, we have Lolita, and we have Nimra Ayaz. That is me. So just Zaheen Fatma, she's the presenter for today's session. She's a final year MBBS student. She's also a research intern at CHSR. She has been a head of publications at SYNC. It is one of the leading societies in our college. She has also been editor of FMH College magazine. And she's very passionate about medicine and research, and the fields that really excites her are endocrinology and psychiatry. Next up, we have Runa Khan. She is a public health consultant. She will be discussing the papers with us today. She's a Fulbright scholar. She has graduated from Chilean University School of Public Health and Tropical Medicine. She has also been public health consultant and nutritionist. She has worked with WHO as infection prevention and control consultant, and she's very passionate about strengthening health programs, implementing appropriate health policies, and most importantly, reach the disadvantaged group with the available and culturally relevant program. We welcome you, Runa. Next up, we have Lolita Matyashova. She is a PhD student in Ukraine. She has been a resident in internal medicine. She has done some exceptional research work and has published about 3 to 4 papers in various journals. And one of her top achievements are that she recently published in Lancet, but due to the war situation going on in Ukraine, she has recently shifted to Switzerland. Lolita, we show our solidarity with you, and we condemn all sorts of wars occurring at any part of the world. And we really thank you for being the part of this session today. Thank you. At the end, this is me. I am Nimra Ayaz, and I'll be moderating the session for today. I am a research intern at CHSR. I recently graduated from FMH, which is our college. I'm also a part of CHSR administration. I recently worked on a case report on gallstone alias. I've been president of 2 societies in our college. I've also been editor-in-chief of our college magazine. And now I'm looking forward to do meaningful research with CHSR and offer meaningful work in CHSR and research world. Thank you so much. Over to you, Zaheen.
Thank you so much, Nimra. I'll just start sharing my screen. Can you stop sharing, please?
I am trying to. Just a second. Okay.
Okay, I'm trying to switch on my video, but the host isn't allowing me. Should I just continue to start? Okay. Thank you, Nimra, so much for that lovely introduction. Hello and welcome all of you to our first Journal Club meeting. The reason why I actually didn't download this presentation was just so that I could do this. It's not happening. Wait, once it happens, you guys will understand why. Woo! Okay, I'm very, very excited to be
Yay!
yeah, that's exactly why. Can
That
the
was such
host
a cool
allow me
effect,
to,
Zaheen.
okay, yeah, thank you so much, Jamal. Actually, like I was like, I'm not going to download it just so that I can put this confetti to celebrate at least virtually how excited I am to be the first one and to, just be a part of this, this research center. And it's just very, very exciting. So thank you so much for that introduction once again. I'll start talking about what we will be talking about today. So we are going to be talking about the risk of type 2 diabetes mellitus by ethnicity-specific BMI cutoffs for obesity. Now, I don't know if we have some first-year students or we have, I don't know, I think we have some first-year students. I'm going to try to make it as simple for them as well. So the research article that we're talking about was published in the Lancet Journal, and it's about ethnicity-specific BMI cutoffs for obesity based on a disease, which is type 2 diabetes, and the risk it had in England. And it's a population-based cohort study. So when we're talking about population-based cohort studies, that basically means that we're going to be looking at a population, a certain number of people, like that's our sample, and then we're going to be following that longitudinally and then checking if anything is happening in that population with regards to these things. So what we're looking at is specific ethnicities, BMI body mass index values or cutoffs, and we're looking at the risk it's having to type 2 diabetes. I hope everyone is clear on this with me. Yeah. Okay. Next, before I start, I want to briefly just describe or just talk about what diabetes is. Diabetes mellitus is a metabolic disorder in which your body isn't able to utilize glucose or sugar, and it's not able to use it for energy. So there could be two ways in like diabetes could present. It could be type 1. That means it's an autoimmune disorder, your pancreas, like where insulin is made, there's a problem there. Or it could be type 2. That means that insulin is being made, but your body is not responding to it the way it should. And the reason why I added this picture on this side is that so you could understand clearly that it's going to have a lot of effects on all parts of your body. It's going to affect your cardiovascular system. It's going to cause peripheral neuropathy. It's going to cause, eye changes. Like there's going to be glaucoma. There's going to be like diabetic retinopathy and lots of things. So that's why I just wanted to say this. And before I continue, let me just talk about some random values, which are very, very important. In Pakistan, 17.1%, okay, so we don't have our own data. This is according to the IDF, Diabetes Atlas. Around 17.1% is the prevalence of diabetes in Pakistan. Now that's a big number. When we convert it, like when we multiply it with our population and we check how many people that is, that's about 19 million people. So again, like I'm trying to emphasize the importance of us trying to find out what is wrong here. Why is it that diabetes is happening like so widely? Why is it so widely prevalent in our society or in our population? So hopefully by the end of this, we'll be able to understand a little more about that. Any questions so far? I don't know if you guys can unmute yourself or I'll just take questions at the end.
Zaheen, it's better if we take all the questions at the end so that you can continue the session uninterrupted.
All right, perfect. I don't mind being interrupted, but I think it'll be more smoother that way.
Yeah,
okay.
It will be
so
more.
We'll be discussing. Okay. Chalo. So we'll be discussing about BMI. I'm pretty sure most of you already know what BMI is, what it stands for, what its classification is, but just to revise it a little bit, the current standard BMI cutoff values, ethnicity cutoff BMI values in South Asian, Black, Chinese, and Arab populations. The reason why I put this here is that so you can understand is that has any work actually been done before? Have people investigated BMI cutoff values for non-white or other than white population? We'll be talking about methods. We'll be concluding this session, and we will also be talking a little bit, not criticizing the paper, but critiquing it, and all the questions we'll take at the end. So Now, in the past, studies have attempted to identify BMI cutoff values for obesity in multi-ethnic populations, and they've done that by using small sample size, self-reported disease status, and they've worked on it, but with relatively few minority ethnic groups. So recommendations that were made of recent BMI values, they're based on very sparse evidence, especially for non-white or different ethnicity populations. And therefore, it might be inappropriate to implement these or to, give these values, BMI values, to different or minority ethnic groups. Now, type 2 diabetes, the reason why we're talking about is, like I said before, it can be delayed or prevented. Now, it can be delayed in multiple ways. Firstly, it's very, like, the simplest thing you could do is change your diet. The next thing that you can do is add some physical activity. Hopefully you already have it, just staying physically active. And lastly, like when things are out of control, we can use anti-hyperglycemic therapy. If these things are not working, we could use anti-hyperglycemic drugs to help control the blood sugar level. So the reason why we want to establish BMI cutoff values or to see if there's any relation or link with that is so that we can reduce the risk of type 2 diabetes. Like I said, 17.1%, 19 million people. That's a very, very big number here. Now, the study that we're talking about, it's the first of its kind to actually provide BMI cutoff values for obesity for Arabs, Black, and South Asian ethnic subgroups. So the findings of this study, hopefully, should help guide revisions of current ethnicity-specific BMI cutoffs so that we can trigger action to reduce the risk of developing type 2 diabetes and also equalizing opportunities for the increased prevention and early diagnosis of type 2 diabetes. Now, what is BMI? BMI is a way of classifying degrees of excess weight in an individual. This classification was made in 1993 by the WHO, which is approximately 3 decades ago, a very, very long time ago. So to calculate BMI, it's a very, very simple formula. You just take your weight in kilograms and you divide that by height in meters square. There are different ways that we can then classify the value that we get. The normal range is 18.5 to 24.9. That's the average, right? And underweight is below 18.5, and above that, we start going towards obesity. So anything above 25 to 40 would be classified as obesity. And again, obesity has different classes. You have class 1, 2, and 3, in which you have moderate to severe and very severe risks of comorbidities. Again, these were made with regards to the white population, and they were never classified, or they never took ethnicities into consideration. Now, again, there's been increasing evidence of high prevalence of type 2 diabetes among Asian populations at a lower BMI than in white populations. So obviously, like when a patient comes to you, you actually check their weight, you check their height, and then you calculate their BMI. And then later on, if they develop diabetes, you start wondering, oh, was it because of their weight or so? So people started to notice that there was a higher prevalence of type 2 diabetes with a lower BMI. So in response to this, in 2004, the World Health Organization and the National Institute for Health and Care Excellence, NICE, they recommended a cutoff value of 27.5 kilogram per meter square for the South Asian and Chinese populations. So the thing with that was that they made these recommendations with little or like basically no data on any association of BMI with type 2 diabetes, and without any data on Black, South Asian, and Arab populations. So there was very, like, they had no data, but they just implemented it because they were like, oh, well, something seems off. Let's just decrease that. Let's just bring it down a little bit. So this study was then conducted. And what they did was that they took electronic health records across primary care facilities and hospital care, and like the data as well as follow-up for quite some time. So the eligibility criteria for that was individuals that were aged 18 years or older, without any past or current diagnosis of type 2 diabetes. Obviously, the population you're taking, you want to see if they develop the disease. So they took people without a diagnosis of type 2 diabetes. And those that were registered with a general practitioner practice in England at any point in time between September 1st, 1990 and December 1st, 2018. So that's around 28 years with at least 1 year of follow-up data. So they didn't take just anyone. They wanted to obviously take a good amount of people, but at the same time, they wanted enough information on those people. Now, what was the exclusion criteria of this study? The exclusion criteria was a BMI of less than 15 kilogram per meter square and more than 50 kilogram per meter square. So those people were excluded, and people who were of mixed race or part of any ethnic group other than white, Black, South Asian, Chinese, or Arab, because this was basically their sample data. They didn't want anything like mixed race because maybe there could be some differences, we don't know. People who had any missing ethnicity data or did not have a follow-up period of at least 1 year, they were excluded. So they wanted to take people who had at least a follow-up of 1 year or 18 years and older. They had a BMI of between like 15 to 50, but not less than or more than, and were not mixed. Now, the procedure was that the data that they collected on the age, sex, and self-reported smoking status, they also collected along with that any socioeconomic position, their height and weight, obviously, to calculate their BMI. And to standardize this, I think they said in their paper that the height was measured using a stadiometer and weight was measured using a class 3 weighing equipment. So after all of this, they tried to get their earliest BMI recorded from the date of the patient's registration at their current practice, and the practice is up to standard date, or from the date at which the patient turned 18 years or older. So whatever information they could get hand on and they could follow up with. Now, I want to briefly explain reverse causality before I talk about this. Normally, what we're going to expect, the usual, is where X has an effect on Y, or X is going to be causing Y, right? So over here, what we're wanting to see is that an increase in BMI is going to increase your risk or increase the chances you get diabetes. But what happens normally is that when people often get diagnosed with diabetes, they're going to be changing their lifestyle, right? They're going to be adopting weight control behaviors or weight loss. So that could actually like cause reverse causality, in which there would be Y would be causing X, Y would be having an effect on X, if that makes sense. So I'll just read this too. So if a diagnosis, after diagnosing someone with diabetes, the 12-month period following the date of the earliest BMI record from the risk period was excluded. Because if the diagnosis of type 2 diabetes were recorded at the same time or soon after the BMI record, they could have influenced the BMI measurements. Like I said, the BMI might have gone down, and then it would show us a reverse effect, right? I hope that makes sense. Now, patients with type 2 diabetes were then identified by caliber phenotyping. Caliber phenotyping is something that's like, it's got all these lists of diseases online. You can check it up, and they have their patient data and they cross-source it. There's a lot of stuff that goes on there. So they did that to classify and to consider only people with type 2 diabetes after their earliest BMI report. So again, the ethnicity was self-reported. Like obviously when you get that, you know, your nationality and all of that, it was self-reported ethnicity that was identified by the use of read records recorded in the CPRD, which was the primary care data I talked about earlier, and on ethnic group, country of origin, and language spoken. So it was reported on the basis of that. Now, statistical analysis. So they identified BMI cutoff values that were risk equivalent to a BMI of 30 kilogram meter square and 25 kilogram per meter square. And it was for the wide population, it was age adjusted and sex adjusted. Negative binomial regression models were used. So that means that to just minimize the over dispersion where mean isn't equal to variance, with fractional polynomials for BMI, and they were fitted according to the ethnicity data in type 2 diabetes. Then again, cluster robust standard errors were used. That's when you have different clusters and you're just taking out the standard errors for that. Negative binomial, again, like that was just taken for over dispersion to just check the effects on that. Calculations were done and then results were analyzed. Okay, so now we're going to come to the results part, which is obviously the main jug, and I think everyone has been waiting for that. Around, for this study, 2,249,438 individuals were taken, which were aged 18 years or older, all right? And then from that, around 776,619 were ineligible because of certain factors, like they were mixed race, they did not, like, with an initial follow-up period of more than 1 year, like, or less than 1 year. They had missing ethnicity data, or their BMI was out of the pre-specified range. So in the final data set, they had around 1 million, 1.5 million, a little less than 1.5 million people. Okay, so to make this easier to understand, I just tabulated it a little bit. So the thing was that, again, like I talked about earlier, they took it for 30 kilogram per meter square and 25. Now, population-wise, white population was around 91.3%. That's a large number, but you need to take into account that the other populations were also like significant. It wasn't like they were less. So the median age of diagnosis was around 67 with a range of 57 to 76. And I'm going to mainly focus on the South Asian population because that's our region. There was a population of 5.8%. And the median age at diagnosis was 55, but it ranged from 45 to 65. The BMI cutoff value at 30 kilogram per meter square for the white population. In the South Asian population, it was 23.9. There is a big reason why I'm specifying that, because for the longest time, I thought 23.9 was decent. It wasn't something that I should be worried about, but maybe we do need to be worried about lower BMI cutoff values as well in our setup. And at 25 kilogram per meter square, it was 19.2 kilogram per meter square. So the risk for the white population compared to the South Asian, you can see there's a drastic difference of at least 6 to 7 kilogram per meter square. So that's why I think this research is very important for our setup. I've written the values here too, like you can see in comparison with the Black population, it was 28.1. Now 28.1, 30, okay, there's a little bit, but it's not that significant. 23.4 again, like I feel like it's still closer compared to 19.2. Then for the Chinese population, it was 26.9 kilogram per meter square. I want you guys to even focus on the median age, because when a patient comes to us, probably when we start our clinical years, we need to be focusing on this too, as well as their BMI. So our for the South Asian population, for our population is 55. For Black, it's 54, and there's certain risk factors in that population as well that predisposes them vascular issues. In the Chinese population was 52 to 68, but like 68 and 65, like just have a look at these numbers so you can understand. I've even written it so I can explain it further. So for the equivalent age-adjusted and sex-adjusted incidence of type 2 diabetes at a BMI of 30, I repeat, the BMI cutoffs were 23.9 in the South Asian population, 28.1 in the Black population, 26.9 in the Chinese population, and 26.6 kilogram per meter square in the Arab population. So further adjustments were made, and they found out that the smoking status and socioeconomic position did not hold any substantial change that would add any difference to our values. And again, when they did it for 25 kilogram per meter square, the BMI cutoffs were 19.2 in the South Asian population, 23.4 in the Black population, 22.2 in the Chinese population, and 22.1 in the Arab population. Now, this is just a graphical distribution. So in the South Asian population, like I said, it's around 23.9. If we're looking at the type 2 incidence on the y-axis, or on the x-axis, the BMI, it's 18, 19, 20. So at 23.9, we stand around somewhere here. The Arabs are around 26.6. The Chinese are 26.9, and the Blacks are 28.1, and the white population is at 30. Again, if we break that down, the South Asian population into different regions, Bangladeshis, Indian, Nepalis. So as Pakistanis, we stand at 23.5, kind of somewhere in the middle. But you can see that compared to other ethnicities and other regions, we're still like pretty up ahead. For Bangladeshis, it was 21.2. For Tamilians, it was 22.6. Sri Lankans, 23.2. And for Pakistanis, it was 23.5. So I hope this is making sense. So in conclusion, like from the results, we can all understand that for an equivalent of age-adjusted and sex-adjusted incidence, with the white population being at 30 kilogram per meter square, we found lower BMI cutoffs for the South Asian population, which was 23.9. In the Black population, it was 28.1. In the Chinese, it was 26.9. And in the Arabs, it was 26.6. So therefore, like the reason why I feel like this is important is that these BMI cutoff values are showing the importance of classifying BMI for different ethnicities to help reduce obesity-related complications like type 2 diabetes among non-white population. That's a very chunky sentence. I'm going to break it down. I think it's important that we start considering BMI values or BMI cutoff values for our region and for different regions, just so that we can reduce the risk of these cardiometabolic disorders like type 2 diabetes, cardiovascular diseases, and as such. And again, like I feel like it's definitely very alarming that being South Asian, we have considered BMI cutoff values of the white population for the past 3 decades. I feel like, in my opinion, this may be one of the reasons why metabolic diseases like diabetes mellitus are highly prevalent in our region. So again, at the end, I would just like to say that compelling data has been provided to support the complete revision of BMI cutoff values, especially for different ethnicities. And again, further research is required to examine whether the same ethnicity-specific BMI cutoff values for overweight and obesity can be applied to trigger action to prevent type 2 diabetes in other countries, as well as the fact that immigrants from different populations, when you think about it, like they might be subjected to different environmental and socioeconomic stresses as compared to if they were in their home countries. So hence, I feel like factors like these should also be taken into consideration. And lastly, I feel like it's very, very important that we start using electronic data or recording our data online and making such methods, because I feel like it's very important in terms of research to help find out what could be the problem here. So I think paper is all now. Again, we're obviously we're virtually meeting from all around the world. So lastly, to summarize, BMI is not just a way, I would say, to classify ideal weights or obesity, but it's also a very important tool to identify high-risk populations in regards to different diseases. Again, I repeat, it's not just something that you can calculate for just, okay, this person is overweight, this person is obese, this person is underweight. No, it's actually telling us a lot more than that. And it can help solve a lot more problems, hopefully, like if we take actual proper advantage of it. Again, researches like these should be brought to our attention, mainly so we can use this data to implement changes in our region, to focus on our population and actually understand the cause of these diseases, whether it's actually just BMI, whether it's our diet, what is it? Like, we know that there are a lot of things that we all love having desserts from different restaurants, especially Rina's. So more work needs to be done on ethnicity-based populations in our region, as we're currently following many cutoff values from the white population. So hopefully, in the near future, we'll be doing that. So before I end, I think this is a good time to start taking any questions. Do we have any in the chat?
Can I be first question? Thank you, Fatima, for your esteemed presentation, for this good article. I have a question. What do you think, to your opinion, is limitation for the study?
The limitation, I feel, would possibly be one. In my opinion, I felt like maybe they should have taken the same population sample. Like there were a lot of white people, and the Pakistani population was less compared to that. But that makes sense because obviously in England they're not going to have the same number of people, and they used whatever data they had. Other than that, they took ethnicity. They took different ethnicities, which was pretty good. Nothing like this has been done before. One limitation would be that they could probably check it for other BMI values as well. Like they took it for 25, 30, maybe include like the ranges of 30 to 40, 40 to 50 to see whether this actually keeps going or if there's like any limitation there or such.
Thank you. Also, like a little bit, I think this work could be also be more give more results if they were included waist circumstance, because, for example, white people and Asian people will have different body composition. And then just for example, like we have, let's say, actually the diabetes started in them like 24, like 27. So it's actually with this overweight, yeah, they have actually like obesity. If you will measure waist circumstance, it's like 80 for women and 90 for man. And also the limitation is that the people with different ethnics were taken in England, but not in their culture and not in their country.
Exactly. That
genetically we are differently, yes. Like sometimes, yes, like I know. I mean, like what we would prefer, yes, ethnically. And when they in England, they can't eat ethnically food which they're supposed to eat, yeah, like or move, have this quality of life which they have in their own country, like stress. Also, we don't know, maybe they had some pancreatitis also, which could lead to this.
Exactly. And I think I highlighted that as well, that it's important for us to probably mimic this research in our setup, because again, like you said, there are different socioeconomic stressors when you're away from your home country, you know, being an immigrant, because I've lived most of my life in the Middle East, job instability, you know, you don't have your family around, so that adds to your stress. Maybe you're binge eating, like that's going to change your diet as well. So definitely thank you so much for adding that.
Thank you.
Any more questions?
If we like, maybe someone shy, we can also like add more something.
You can type it in. Yeah, I'm just waiting that people can just type in if they have any more. Thank you so much, guys.
They hadn't like maybe income of person, because if you will also look, if the person have like different income, they are like body weight and lifetime diabetes can be different because it's like
so
when
I think they tried.
Yeah,
they tried taking this socioeconomic quintiles. They took socioeconomic quintiles, so I feel like maybe that was their way of checking the economic position or their salary probably. But they found out that there was not much of a difference with socioeconomic position and with smoking. I was actually shocked about the smoking status part, because I definitely felt like that would have an effect, but that actually didn't have a significant effect.
Yeah, but like smoking, it's like more for cardiovascular disease. It's like not for type 2 diabetes. It's like not so much influence on it.
But I felt like maybe it would add to the cardiometabolic disorders or something like that. So that was interesting.
Yeah, it's like Ali wrote, that's like really good comment. That this study highlights the need for research on data from our own population, like how we say, yes, need to bring in more data to devise cutoff representation in our own population. Yeah, if we will do it, we'll have it, it will be make really, really good things, and we'll put more lights on it.
Definitely, Marok, I definitely believe that the population sizes were very different. But again, when you're looking at it, like, because I feel like 386 is the number that represents the whole population, something around those lines. Like it's not a true representative, but if you have a number greater than 386 people.
And also,
again, like I did.
I want to add, because like it's like not so yeah, it's like different size, but if you will use how they use proper methods of like how it's like, I forgot these words, you know, like in statistics, so proper method in statistics, you can equalize this difference. So it's like not so much of a problem. Yeah. If it will be like 10 and 1,000 will be, but like in their study it was good.
That would be a big difference. was advised to add 91% of the white population in the study, even though it was targeted to study. I feel like the main reason why they probably would have added the white population in that significant amount, or just to add the white population, was that so we could have a good comparison tool. Like we could have a good comparison with the white population and the different ethnicities. But again, like obviously they had more data on the white population. That's why they probably took a larger sample of white people.
All right, Zaheen, thank you so much for such a wonderful and elaborate presentation. We are so proud of you. You've done a great job. Thank you so much.
Thank you so much. Thank you so much, Imra, for having me again. If anyone has any questions regarding this, you guys know where to find me. I'm usually sitting in the lecture halls or probably in the hospital, and you guys just message me on WhatsApp or whatever it is. I'm always accessible to my juniors, especially.
All right, now I would like to invite Runa Khan, who is our discussant from today. She's joining us from Tulane. So Runa Khan, we welcome you, and over to you now.
Thank you, and hello everyone. My name is Runa, and I completed my bachelor's in nutrition, and then I did my master's in public health. The specialized field was again nutrition and food security. The presentation was very nice, Zaheen. I really appreciate your efforts. I would want to add few of my experiences when it comes to BMI, the body mass index. During my time at Tulane, we had this one course, introductory course for public health. And in that course, one of the presentations was presented to us by the dean of from the School of Public Health. And that presentation discussed how ethnicities are discussed nowadays. Like ethnicities are no more the way they used to be. For instance, in the United States, you cannot just look at someone's color and say that that person is either white or black, or that person is South Asian. People from different races are getting married. They have different ancestral line. They have grandfathers and grandmothers from different races. So that kind of, again, is a confounding factor when it comes to BMI. I, for starters, don't like BMI as the screening tool, because BMI doesn't let you identify those hidden factors which should be taken into account when it comes to determining what is our health and nutritional status. For instance, if someone has more muscle mass, then the BMI would show that, oh, that person is overweight or obese, but realistically, that person would be the most healthy person. Same goes for a person who is very lazy and have a lot of fat in their body, but no muscle mass. And their body mass index would be perfectly fine. But no, again, that person won't be healthy. And then comes the bone density. There are people from different ethnicities, races, and also genders that have different bone densities. Some people will have stronger bones, some will have weaker bones. Even among women, there would be differences due to their hereditary factors. So again, BMI cannot be taken as the standard tool for determining the health status, especially as discussed in this paper, that BMI is a really important tool when it comes to determining if someone has diabetes. Now, if we are going to determine if that someone has diabetes, the BMI would be different for people from different countries and races. This study is again done in England, which again, as Zaheen mentioned, that could be a confounding factor, because people who live in England might not have those kind of stressors or diet that kind of would affect their body weight. In my experience, when we were in United States, people from different countries, the international students often felt that they were gaining more weight when they were in US as compared to they were in their own countries. People from India, Pakistan, Bangladesh, Congo, Algeria, Palestine, all of these people felt that they were gaining weight. So again, changes in an atmosphere, changes in environment, physical activity, dietary stressors, how they are like consuming their food? Is it more sugary, or is it more carbonated? Is it more water? These all factors are highly essential when it comes to identifying what kind of tool should be used as a standard for determining the nutritional and health status. Again, this could be one of the topics that on which one can write a paper and address the WHO and the other health organizations, that BMI should be really think over, and it should be considered again, that whether should we keep it as a screening tool or not.
Those are very, very valid points. Thank you so much, Muna, for adding those in, because I feel like we have been looking at it like as an important tool, but definitely there's so many, with all these metabolic diseases, there's so many factors that are actually going into play. It's not just obesity. It's like, you know, you've got your genetics, you've got your diet, you've got your lifestyle, and it's like, just because maybe I am not physically active doesn't mean I'm going to get diabetes. But someone else, maybe if they have, like, if their parents, both of them have diabetes, there's obviously a higher chance that that person being physically inactive is going to get diabetes. So there's so many things that go into play, so many risk factors.
But
can I add, please? So here, like, two of you, like, really, really good talking about, like, I can't, like, say too much, like, really good point and so on. But also here we are talking about, like, articles and, like, science work. The main, like, when you take in, like, a journal club, yes, it's like, is it like the work good? So the design of work, it's actually good. And, like, what the most important things for when you have a research, yes, that you can repeat it in this environment. And so as a result, if we will repeat in Britain, we will have the similar results. So it will be so essential to people in Britain, for doctors in Britain, because they will meet these people, like Asian and so on. Yeah, they, like, we can say they wouldn't, like, of course, they have different food and so on, but, like, we cannot influence on this. It's like, you know, every time when you have, like, some guidelines, especially some research, it's like how the way you look. If I will look, yes, I will say also, like, I treat a patient with obesity a lot. I will say, like, I will, like, go, like, to the weight circumstance, but, like, we cannot, like, argue with statistics they don't lie, and, like, the time. If it was some, like, bad things in methods, yes, some calculation, we would say, but, like, it will be work in Britain, and maybe it also will be work in USA, because they will, like, transfer it. And we also, like, cannot argue, like, if you will, of course, if you will meet these people in their own country, it wouldn't work, but it will work in Britain. And also sometimes we also can, like, not argue it's, like, genetic, because sometimes people, yeah, you will look on this person and have, like, obesity, like, really, really bad lifestyle, like, and so on. But he wouldn't, without the obesity, yes, without cardiovascular disease, because he has, like, good genetically. So it's, like, all of the things. It's just, like, it depends on which way you want to look. I can, like, give you one, like 10 or, like, I don't know, like 30 points, like, why it's, like, not so good idea, and then, like, what is a good idea. So both of you, like, true, it's, like, depends which you like to look. And if you will, like, look to in Britain, it will work, and you say it will be the same for these people work. And also, like, when you said about, like, mixed, yeah, when people, like, with different like started, yes, like black mother, Asian father, but, like, also they will have some of them will have more majority of the ethnics. For example, if it's, like, mother, she will put because she will mostly will cooked, and she will give her like, to the family, her eating behavior. So it will be, you know, like, more like to this popular form, more to this ethnics, or they will, like, just, like, took of their you say, like, so. But it's, like, also work. It's, like, which genetically will be more, it could work also.
I have a question from our worthy discussants. Some people in the chat box also raised this question, that if BMI is not that trustworthy or something that reliable, what
is an alternate
we can look for? What is an alternate which could be more reliable and also something that is affordable and feasible?
We have like this answer, like smart people, yeah, like the best like answer to this question already. You just like go to the guidelines and look, and like even in these articles they present like needs and like WHO guidelines. So like you never look only body mass indexes. You need measure it weight circumstance, hip circumstance, like counting. It'll be like different to woman to man. So you will look on it. It's like just like go to the guidelines and you will like check everything we'll need. We can like discuss here whatever we want, like every articles, but like we cannot argue with the guidelines. Anyway, it will be off-label.
Yes, as Lolita said, I agree. Nutrition is not a very old field, although we have been eating food, but it was never studied the way it should have been. It's quite recent. Even in Pakistani universities, the nutrition courses are still kind of rolling, and same goes for the other countries. So as Lolita said, that one should be careful and take into account those hip mass ratio, the fats that you have around your body. Like you can check the when it comes to malnutrition, they always do the MOC, the mid upper arm circumference. So it's for the malnutrition. But again, if people are healthy, they can check other parts of their body and measure them, that what is the fat on their parts of their body. Like they can check here on their waist, they can check the thigh fat. Everyone will be able to identify if they have fat or muscle. If you have fat, it will be like sagging. If it's muscle, you will have lean body. And you will also feel strong inside yourself. Like if it's okay, how I determine my body mass index without going to a lab, okay, then you can see or feel it when you run or you do exercises. You will feel that, okay, your bones are not weak, your knees are not giving you a tough time, your ligaments are not weak. So these kind of internal messages from yourself to your brain would be kind of helpful when it comes to measuring your own health.
But
yeah, but like don't forget, sorry, like don't forget, like not just like looking at like you have some fat, because for women women need fat, some like small fat. So like just like because like hormones, because you know like you can always like I can like find like fat in myself. Just like go to the guideline, like measure it your waist circumstance, like and like find this and compare it with body mass index, because like man, for example, who is like really strong with huge muscles, they have like can have like body mass index like 31, but they would like without like fat. So
does that mean that we need more papers which look into individual parameters and then relate those parameters with the prevalence of diabetes, or we can use more than one parameter in one paper?
You can use actually in one paper, for example, it's like for this, if they would have also waist circumstance, hip circumstance, it like even could be neck circumstance, and I don't know, like more fat percentage and so on. So in these papers, I cannot like put also like low like cholesterol, I guess LDL something. But they can like put more measurements if they had it, but they hadn't, because it's not ordinary what doctors measure it, or they measure it and like not put it in the system because it's take more work. So we just like you can like just like so how it like happen in real life. You just say, okay, what is what is your weight? Yes, like I will like write and like hi, and then I will see yes, it's like he's like have like huge weight circumstance. So sometimes it's like only who will measure it. It will be measured like doctor who treats obesity, yes, like or endocrinologist. More doctors could be like without time, so they wouldn't put it in our doctors, because like here we have a huge data. So that means the patients will go to their hospital. Anyway, you know, like we should consider also this data about like people who came to hospital, and just like imagine how many people doesn't go to this hospital because they're they cannot afford, they don't have time, I don't know, like some insurance or something. Yes, so it's like also the could be gap. But actually, like you know, like as you like for your next time, check some like articles, like not in the Lancet. So this like can be somehow like bad things in the methods and the designs. So then like it's like nice to find this like gaps and discuss how it will be made it right. So like to look how not to do this and so on, it will be more fun.
That's very true. There were very few limitations that were actually written in the paper. I felt like they were just like going like, oh, we're amazing. We did the right things. So yeah.
So we have some comments in the chat box as well. Abbas says that I was thinking a waist to hip ratio could be a more appropriate index. And then some Adil Rahim said pelvis sizes vary between races. Abbas again said that abdominal obesity is more significantly associated with insulin resistance. And then Adil again said that we can use more than one index to eliminate other biases. And at the end, we have a comment by Dr. Hamad. He says that free fatty acids lead to the insulin resistance. So we need to look into multiple factors affecting free fatty acids as well. So what do you think about these?
Yeah, good. Yes, it's like abdominal obesity is like more significant we know this is like a fact. So because if we do all measure, it's like with circumstance. More than one index can be used. Yeah, but like we have like standards. I don't know, like more index. Yeah, so for example, I know like index like which like we can like find and get body mass, and for example hip and with like waist circumference. And another one, if you want to use, you need to be sure that it's like valid, because we can like make new, or for example, index, but we need to. So if you at first will like write about this index, like make a research, publish it, it will be good. So you can like use it. It will be, of course, limited their biases. And so pretty and the last one. Yeah, it's like could be, but like also it's like difficult to do in one research. Ordinarily, it's like when it will be, if it's like a PhD things or like research, so you will like also check it, and then you will have like 3 or 4 articles to check all this to write. Because if you will put this all information in one article, it will be that there wasn't their goals. So, and also like insulin resistance, they will check only of level of insulin, so also like can be difficult.
So I feel like in regards to this research, the reason why they probably used BMI was because they were trying to find large enough data going back. And BMI is something that's very frequently when you go for a visit to the hospital, it's something that obviously, they're going to check your weight, they're going to check your height, they're going to record that. So that's very easy access to that data in a longitudinal study. I feel like that's one of the reasons why they mainly use BMI. But yes, definitely, I feel like we can use other parameters like waist to hip ratio, and especially with regards to if we want to make something
really nice.
Skin fold measurement, yes.
Yeah.
So we can do that. I found it very interesting because that's true. Yes, we did study that pelvis sizes vary between different races. And if we're going to be taking that ratio, that might have an effect on it. Again, like, don't actually know how much the bone is inside all that tissue. Probably use x-rays and things like that.
So I think this discussion gives a lot of work to CHSR. I think all of us have a lot of ideas to work on from here on. We can conduct these studies in our setup as well. Runa, do you have anything more to add?
No, not at this point.
All right. Do we have any more questions? Zaheen, you started sharing your slides again.
Yeah, the reason why I did that was because before we end, I just want to use the confetti thing again.
All right.
Because it's actually like, I'm so happy that we've, made this journal club and we've taken this initiative, and we had such amazing speakers, both of you. Thank you so much for being our discussants. It was enlightening talking to you, and you added some very valuable points that probably we as students would not have been able to notice at our level. So thank you so much. Again, dedicated to research.
All right, Zaheen, thank you so much, especially for the confetti effects. I think that really lightened up the mood twice, before starting the session and after starting the session. So I believe that is a wrap. I really want to thank you, Zaheen, for such a wonderful presentation. I would repeat again, you've made all of CHSR really proud. And
Thank you so much for having me. I'm so happy that I could be the first. And hopefully the others after me are going to be even better because, you know,
Nimra, there is one more question in the chat box. Kindly, if you can take this question with your discussion.
Yes, sure. Yes, sure. So Dr. Essen have a question. It says, if high BMI is a risk factor, do you think controlling BMI is all that's important to reduce the risk of diabetes mellitus?
I've been waiting for Dr. Essen to speak the whole session and I was like, finally. So should I take this question out? Like, I think we've discussed it already in further detail. BMI is one of the risk factors, but there are obviously, again, lots and lots of other things that are going into play. It's not just BMI that's causing the disease, but yes, in terms, maybe BMI, obesity in that sense is an important factor to reduce the risk of diabetes mellitus. But like we discussed, BMI, it's not just BMI. I feel like Runa Khan, she put up very valid points that you have your bone densities that are going to play, your muscle mass. So BMI could be misleading, but if we're going in a longitudinal study, I feel like it's not that bad of an option. Okay.
I will add also, no, it's like wouldn't be enough. You need like again like weight circumstance and also like the most like lifestyle. Yeah, it's like the most things. If you will go like to any recommendation like for prevention, you will like say lifestyle modification. So it's like movement. You can like have normal body mass index, but if you wouldn't move, you can like have diabetes. If you will have drink a lot or like alcohol, have like a lot of episodes of acute pancreatitis, you will have type 2 diabetes. If you will eat only light carbons, you will have type 2 diabetes. So it's like not only one way, and also like you have really bad genetics, you couldn't run from that. So it's like always multiple, and like for every disease, it's like not only one thing, maybe only for only genetics. Yeah, it's like all multiple. So we should look from the different parts of it, and like even from the study, we see that like people have like not all people have with obesity, diabetes. So it's like always to look in different sides.
All right, do we have any more questions? Come on, CHSR, questions. We need more questions.
Okay, I have questions. Okay, Fatima, what do you think if from this article, doctor in Britain should be more aware when they see Asian people and somewhere, or if they need to make them more recommendation of prevention?
I feel like definitely after this, they should be more, way more aware because it is highly prevalent, maybe within our genetics, or if it's the BMI, whatever. So when a person probably 30 onwards, if they're coming and they're having these, it's important to identify it when they're pre-diabetic or before they actually get the disease, because like I said, you can prevent it with lifestyle changes, dietary modifications. So they should definitely be more aware of this, but not just South Asians. I feel like even different ethnicities, they should be more aware of it. Yeah.
Mm-hmm. Okay, and also one, for example, when you will go to the inclusion criteria of the study, there was like age from the 18 and like till above it. So
18 years and older.
Yeah, so it's like really wide, you know, like when so young, and if this was made correct or like was this we should made it like differently. And also again like another one, it's about like they took body mass index under 15, but like you know, like for example, patients with 16 body mass index is also like so thin. So
yeah, they maybe they could have changed it a little bit. But I feel like, again, they probably wanted a bigger sample size to actually give something substantial. So it comes down to that.
Yeah, maybe because most people was thinking like in what age it could be. Yeah.
Yeah.
All right.
Again,
So
because if the person is 18 and then you're following them for nearly 30 years, so like that person's gonna be 48 then. And after 45, we know that, you know, as you get older, you have a higher risk of type 2 diabetes mellitus. Maybe that's why they started with the younger age. They had substantial amount of data to actually use in their research then. Could be.
all right, I think that's a wrap. Thank you so much, Zaheen. I really want to
Thank
extend
you.
my special gratitude to Dr. Lolita and Dr. Runa, who
Thank you so
joined
much.
us from abroad, and they really extended their very expert and valuable opinions on this paper. This paper definitely was a game changer and a perception changer, especially for people in Pakistan and obviously
Definitely.
South Asia. So I think discussing this paper and choosing this paper as the first paper of this journal club was a very wise idea. Obviously, from now on, when we reach back to wards, we will see people, we will see their BMIs and their body structure and all of that in relation to diabetes differently. So thank you so much, Dr. Lolita and Dr. Runa, for joining us. Thank you so much, Zaheen. I think this is a wrap. So thank you so much, everyone.
Thank you.
Please fill out the forms that Dr. Hamad has shared in the comment box. We need your feedback all the time so that we can improve our work every day. Kindly fill that form again. And I think we'll be signing off now. Thank you.
Thank you so much.